Let me start off with the instructions from my lawyer. I do not have any financial interest other than the fact that I helped fund this event, and I'm glad to do it. I don't have any conflicts, real or apparent, regarding the context of this presentation. So, with that out of the way, let me make sure I can advance the slides. So what I want to talk about is how to advance the slides first.
Oh, sorry, I made that.
Okay, so first of all, thanks for the opportunity to be here. And I want to talk about just a few things from the State Department of Health's perspective regarding the whole concept of crisis standards of care preparedness. So I'll start off with generally what I feel is our approach to becoming what I call crisis ready. And really highlight some key themes that are influencing our work. Secondly, I want to talk about sort of our work plan and how that has dramatically evolved in just 2 years. I'll share with you kind of where we were literally 2 years ago today with regard to healthcare preparedness across the state, and where we are today and where we're going, and then provide some very specific updates on progress on a number of key issues. Okay, so I was first, I guess, exposed to the concept of preparing for crisis conditions when it was called altered standards of care way back when, and I think it was the H5N1 period around 2005, 2006 that galvanized the entire country, really the entire world, into focusing on a level of readiness that was different than what we had before. We have clearly a dramatic earthquake threat here in Washington State. We're going to be experiencing in 6 weeks an exercise to end all exercises for 5 days on the Cascadia subduction zone. And it's pretty clear to everybody, I think, that that those types of major catastrophic disasters warrant a response that's very different in a lot of ways from what we're used to. But I think it's the wrong approach. I think it's a very wrong approach to tie crisis standards of care, planning, and preparedness to catastrophic disasters. The reason is because all disasters impose change on us. We don't have a choice. As John mentioned, we don't choose to exist within a crisis standard environment. The disaster dictates that to us. And the extent to which we will experience crisis conditions, I think, is a combination of, one, the severity of the impact that we experience, and two, the degree of vulnerability. And I believe our healthcare system simply is not resilient. Resilience in the business world equals inefficiency. How many extra beds do we have lying around that we can surge into? How many healthcare facilities have a whole warehouse full of supplies that you can dip into when the supply chain is disrupted? What happens if we have just a minor disruption in our water infrastructure or in our road infrastructure? We're not designed to be very resilient. And so from a standpoint of sort of a broad approach to this, it's not about preparing for the catastrophic event. Any disaster can push us from really conventional, but I think mostly we're in contingency levels on a daily basis, right up into crisis. And so the idea is, how can we operate successfully in that environment and get out of it as quickly as possible? And just finally, a bit about legal preparedness. I'll talk more about this as we go. But a core component, certainly, of being crisis ready, but people jump right to that. You know, crisis standards of care is about legal preparedness, and the only thing in legal preparedness is liability protection for healthcare workers. Again, I think a very wrong approach. Legal preparedness is important. It's one of the 5 pillars of crisis standards of care readiness, and we'll talk a little bit more about those. But I believe immunity protection for healthcare workers operating in a crisis environment is one tiny sliver of a broader book of tools that we need to prepare. To be legally ready for a healthcare emergency, we need to be able to address the concerns that arise in any disaster. And for example, I've been in Washington State for 15 years and experienced an awful lot of disasters that have occurred across the state. Not a single one of them, in my view, has warranted the initiation of legal immunity for healthcare workers. Not a single disaster in the last 15 years has risen to that level. We have come very close, and we have gotten very lucky in a number of circumstances, so we can't take credit for that. It will happen. It is inevitable. We are going to experience this. But what we have implemented in the last 10 months are legal waivers to support healthcare facilities to avoid getting into a crisis situation, to respond under the circumstances they were experiencing during a disaster, to continue to provide an optimal level of care under those conditions. That is something we will use probably on a yearly basis or maybe every other year, but we need to be absolutely ready to pull from all the legal tools that we have, all the types of waivers and support tools that we can initiate at the state level and at the federal level to support healthcare in either avoiding crisis conditions or in getting out of crisis conditions as quickly as possible. So just a very different approach and perspective than what we've taken in the past, and I think it's very important to recognize that. So John talked a lot about sort of the pillars of crisis standards of care planning, and we're engaged in a number of these areas, developing triggers and indicators, for example, for state level decision making, and of course the legal preparedness component. But I guess from a broader perspective, our overall statewide work plan for healthcare preparedness in Washington it used to be, actually 2 years ago, it was limited to one component, and that was the 8 healthcare coalitions could pretty much decide whatever you wanted to work on. As long as it satisfied the conditions of our federal grants, which were pretty broad, healthcare coalitions could just do whatever you wanted to do, whatever you thought was important. Almost none focused on response, and almost none focused on the core components of crisis standards of care. Well, that has changed completely. Our entire statewide work plan now is entirely found within the Institute of Medicine's guidance regarding a systems framework for crisis standards of care. There's not a single thing DOH is working on, or any of you are working on with grant money that we provide, that is not directly found in that systems framework. So if you don't know that systems framework, you need to get it. You need to read all 7 volumes. They're very, very short. They're very easy to read. But if you want to know what the state's doing, it's in that book. If you want to know what we're going to be doing in the future, it's in that book. And what coalitions are going to be doing is in that book. And so the 5 pillars sort of touch on these broad components of crisis standards that are really essential, most of which I believe really should be done centrally, should be worked on statewide. But I think a more important component of our healthcare preparedness planning is this second one, and that is community-wide and ultimately statewide operational readiness. That is what constitutes the entire contract for all 8 healthcare coalitions right now. And that was not the case 2 years ago. That is the case this year, and it's going to continue to be the case going forward. If you don't have the ability to gather information from your healthcare system, in fact, even make contact with your critical healthcare facilities, to accept a resource request and know how to process that resource request, to field basic logistics capabilities, nothing else matters. Who cares what your ethical framework is? You're not going to know how to make decisions because you're not going to have any information. Who cares if you want to be able to ration ventilators? You're not going to be able to get to that point because you're not going to have the basic tools in place to know what's going on around you. So the concepts of operational readiness at the regional level regarding a healthcare emergency, I believe, are actually more important than other elements of crisis standards of care, and that's why we're prioritizing it. So I want to talk a little bit about sort of progress on these key areas from an operational perspective, how we're developing readiness at the regional and at the state level. I want to go a little bit deeper into the legal piece and share with you where we are on various aspects of that, and then talk about the second component of this statewide work plan. There's the regional and statewide operational readiness, and then there are these sort of loosely defined statewide initiatives that I think would be of value and is an area that's evolving pretty dramatically. So operational capability, again, our contracts with coalitions are very clear, they're entirely consistent, and they're going to stay this way. We have to ensure that we can make contact with critical healthcare facilities, and at DOH we've defined that as hospitals, skilled nursing facilities, blood centers, and dialysis centers. You can go beyond that, but you cannot be unaware of those facilities in your community. In fact, we're pushing it to the next level. We actually believe that this is not just a responsibility at the regional level, but that every level of government in the state of Washington, at least every local government in the state of Washington, every health department needs to be able to contact these facilities and assess their status. This is a basic component of emergency management, and we contract with all 35 health departments in the state for basic preparedness capabilities. We're going to add into the contract of every health department in the state that activity. Know who your critical healthcare facilities are in your county and know how to contact them. That's it. Check on their status. Are they okay or not? You don't have to be able to move mountains to help them if you're a tiny jurisdiction, but you have to know what's going on. Every health department has a health officer. That health officer has legal responsibilities and legal authorities to make decisions. Hard to make decisions if you don't know what's going on around you. So the basic components of managing information, attaining situational awareness, and managing resources are going to be, I believe, a permanent fixture in our statewide healthcare preparedness planning. Every region, we're going to, whether a region calls itself a coalition or not isn't important to me. How we invest our grant resources is going to tie in with operational readiness first and foremost. So on the legal front, a lot of work in the past. Again, H5N1 sort of galvanized this in 05, 06. So the state, I'll do a little bit of history and then come up to the present day. The state Department of Health initiated some work groups in 2008 and 2012 to talk about crisis standards and what's important about it. Legal liability protections came up as a priority in both of those time periods. And then in 2013, a bill was initiated in the legislature which was extremely broad regarding providing liability protection for healthcare workers during disasters. It did not pass. A separate bill did pass which allowed for emergency privileging of healthcare workers during disasters, which is another tool that we have. But then in 2014 we came back and WSHA pushed a bill through the legislature that was much more specific. And so I want to tell you where the Department of Health stands on liability protections today. We helped craft that bill. We helped galvanize the healthcare community around it. The enacting of liability protections for healthcare workers during a crisis, I believe, is a government function. It's something that should be initiated by the governor under a state of emergency based on triggers and indicators determined by the Secretary of Health that state crisis conditions exist in a specific part of the state. So the bill really narrows down liability protections to a piece of geography in the state of Washington by county. It's not statewide necessarily, and it's time limited. It's for all licensed healthcare professionals in one or more counties that are defined as being in crisis conditions based on information that show certain triggers and indicators have been met. So there are significant checks and balances on who can initiate this, when, where, and under what circumstances. And I think that's entirely appropriate. Again, this is a big hammer. This is the biggest hammer in the toolbox when it comes to supporting healthcare workers and supporting healthcare facilities in operating under crisis conditions. It should only be pulled out when absolutely necessary. So where we go from here, we didn't push this bill in the last session because it was a short session and everything was about pretty much the budget and education. We're looking forward towards this coming session, but it is an election year, and so that has a lot to do with kind of where the department's position is with regard to the governor's office, and so moving this through the legislature, it can be moved by any organization really. Where the department stands on it is going to largely depend on how things turn out in November. But we are supportive of legislation that would provide this tool to the governor to provide immunity protections. It's uncertain how this is going to move going forward. But I think much more importantly is the broader book of legal tools. Being legally ready means using, as I mentioned, all the tools in our toolbox at the state and federal level to enact waivers, to provide relief, to provide some type of support for pharmacies, for hospitals, for any healthcare facility that we regulate under specific circumstances when specific triggers have been met, to allow those facilities to stay out of crisis or to get out of crisis as quickly as possible. And so part of that involves us researching what's out there, what can we actually do, and the second part is communicating to all of you, what can we actually do? Having a book in front of every coalition lead and in front of every hospital, every healthcare facility that shows different types of waivers that are possible, the circumstances under which they would provide value, and the information that we're going to need in order to make a decision as to whether that waiver is necessary. I think that will be very helpful. And I think there's a lot of facilities out there that have no idea that this is possible. You just sort of struggle through when you're facing a serious crisis. So that part of legal readiness, I think, will be much more valuable in that it's much more likely to be used, as in probably every year. So state level initiatives, this is where we have had a lot of work going on since the summer of 2014. I'm just going to sort of give you a rundown of different things. These are very loosely connected. There's been no sort of concrete and comprehensive strategy to this, but that is one thing I want to change. So we took it upon ourselves at DOH to really go after some key low-hanging fruits, components of statewide operational readiness or components of specific crisis standards of care issues that are contained in the Institute of Medicine guidance that we knew we had to develop, that we had to develop at the state level, and we needed to develop fast. So first, we funded the development of a statewide hospital mutual aid agreement. It's out for signature. I think half the hospitals in the state so far have signed on. I highly encourage all hospitals doing that. We're requiring coalitions to at least connect with hospitals in their region that have not signed on and ask why and what help can be provided to push that forward. Again, I mentioned we have developed a draft set of state-level triggers and indicators that would support the Secretary of Health and the health officer in making decisions at the state level. We are engaging in a responsibility that I think is critical, and that is supporting the EMS community when patient transport goes well beyond just within a region or across regions. And this is the big one. This is a Cascadia type event or a major earthquake in an urban area type event. EMS does a great job day to day. They really work well, even moving to neighboring regions. But when 20 different counties are competing against each other for EMS capacity because they've lost quite a bit of their capacity, and for hospital space that's 3 regions away. That is not something that can be a first come, first serve type of response. We need to centrally coordinate patient movement out of the State Emergency Operations Center, tying in the Department of Health, the EMS medical directors, the State Fire Marshal's office. The reason that's the case is because fire mobilization, which is a statewide mutual aid agreement among fire departments, can control a good portion of the EMS assets in the state. And we want to tie in our federal partners because access to federal transport resources have to be coordinated through that unit. So this is a key capability that we don't have today and we have to develop. And that is tied in with a concept that we're pushing forward, which is to support our disaster medical coordination centers across the state, all the hospitals in the regions that coordinate patient movement on a daily basis. And we established actually a state-level disaster medical coordination center, knowing that during an event where regions are competing against each other for space, most likely in Eastern Washington, who's the quarterback? Which hospital is going to sort of broker available space with the EMS community and help patients get to where they need to be based on their level of acuity? So right now, there are 2 facilities that can do that, Harborview and Deaconess. We wanted one on each side of the state. A key capability that's new for us. We're working with large health systems to ensure that if we have a situation where we're moving lots of medications from the federal government through the Department of Health, across the state through the strategic national stockpile like vaccine or antivirals or antibiotics, we can capitalize on the infrastructure that large health systems have every day and really utilize that infrastructure to dispense medications across their systems. We don't need government trying to become McKesson and Cardinal and AmerisourceBergen. We can't do that. But Providence and Group Health Kaiser and Peace Health and others can do that. And so we want to partner with these health systems to ensure they can receive medications and distribute those medications as quickly as possible. And then finally, we have already learned some lessons from this Cascadia exercise before it's even occurred. And one of the big lessons is that we're going to move a lot of people from the west side of the state to the east side of the state. And a lot of people are going to move on their own. And we need to be ready for that. We need to acknowledge that this is a statewide disaster. And how can we prepare a medical surge strategy that utilizes the resources and capabilities we have in Eastern Washington to support what's going on or what has happened in Western Washington. And this is going to be an extraordinary challenge regarding ethical decisions, regarding operational decisions. Do you surge within hospitals in Eastern Washington and thereby to some extent degrade the level of care in order to accommodate the 20,000 patients that are going to be moving? Do you set up field hospitals in Wenatchee and Spokane and Tri-Cities and Yakima in gymnasiums to provide a certain level of care to patients who have nowhere else to go? Do we bring federal resources in the form of medical teams to support Eastern Washington hospitals in providing a higher level of care? Do we bring those teams in to support these ad hoc hospitals, or do we surge those teams into Western Washington to support the remaining hospitals that are still standing? Do we keep some patients where they are in Western Washington based on acuity and send some patients out of state away from their families based on acuity? If so, which ones and why? Incredible operational, medical, and ethical challenges associated with this. So we're gonna dedicate an entire FTE starting in July to that particular area of planning. It's going to heavily involve Eastern Washington emergency managers, healthcare, as well as public health. So you can see this is sort of a bit of a ramble, and this is what it's been for the last year and a half. We've sort of attacked some of these key major issues that we wanted to address on a statewide basis regarding healthcare preparedness, and of course legal issues and triggers and indicators I mentioned. But the last piece is, what we haven't done is actually asked healthcare executives and key healthcare personnel what you think. In fact, I've been in this position 2 years. I was with Seattle for 11 years, and so I've been around since the very beginning of the healthcare preparedness program. I'm not sure we've ever asked healthcare executives or healthcare personnel, what do you think of the statewide healthcare preparedness program? What do you think the most important things are that we should be working on? Are there things that we should stay away from? What's most important to you? And it may differ from one facility to the next or from one system to the next, but I think we've done a very poor job of even posing that question. I can come up with these, I came up with these items here on the list, and I could come up with a lot more, but I'd really rather have this component of our statewide healthcare preparedness work plan directly informed by healthcare. I think there's two key components: regional operational readiness and sort of statewide capability development. And we need to do a better job, I think, of incorporating healthcare's voice in that. So that is something that I'm committed to going forward in the coming year. And so that's a brief summary of kind of where we are and what we've been doing, and I'd be glad to answer any questions.